Okay, let's roll it. So hello everyone. Thank you for joining us for today's webinar. My name is Dr. Yvonne Serrano Duque and I'm the Senior Public Health Specialist of Asian Disaster Preparedness Center, your moderator for this webinar on mental health in emergencies, greater investment, greater access. Moderating the sessions with me is a medical anthropologist and the co-founder of the Good Practice Group for the development of MHPSS services, no other than the co-director of MHPSS.net, ladies and gentlemen, Mr. Ananda Galapati.
Thank you so much, Yvonne. It is truly a pleasure to be co-hosting this exciting panel with you today. We have a lot of great speakers who will share experiences, good practices, and approaches to coping with COVID-19, and also provide recommendations on approaches for greater investment and promoting access to MHPSS care and services for everyone. And I'm particularly excited because this important conversation is bringing together really diverse experiences from across Asia and from beyond. COVID-19 has underscored, I think, more than perhaps any other previous emergency at a global level, the importance of MHPSS in crisis response. And WHO actually reported recently that 89% of 116 affected countries that they surveyed had included MHPSS in their national response. But I'm afraid we have to have soberingly note that only 17% of the surveyed countries had actually allocated any additional funding for MHPSS activities. So I think the experience of the pandemic must propel us to ensure continued provisioning, but also secure better resourcing of MHPSS going forward.
I totally agree with you, Ananda. And I totally believe too that there is no health without mental health. So always remember, we have to take care of our mental health. The mortality reports, the number of cases recovered on COVID-19 is just tip of the iceberg. Multifaceted issue seems to have affected everyone's mental health in this pandemic.
So we're going to get started now, and we'll have two sessions, two panels, in fact. But I'd like to just share a few housekeeping tips with you before we get started. As we'll be hearing from a number of different presenters, we'd like you to put your questions that you have or comments perhaps that you have about the presentations in the chat box in your Zoom control panel. And we will, colleagues at ADPC and the rest of us on the panel will be collecting some of those questions to take them up during the question and answer portion at the end of each of the sessions. A recorded version of this webinar will be available and shared with you and others afterwards. And again, a really warm welcome to everyone who's just joined. We are now at 220 in the room. Welcome to you all.
Okay, to open us and welcome us in this webinar, may we welcome ADPC's Executive Director, Mr. Hans Gutmann. Take it away, Hans.
Okay. Well, dear participants, colleagues, ladies and gentlemen, welcome to this webinar on mental health in emergencies, greater investments, greater access. How do we make mental health and psychosocial care services available to everyone? But before considering the question just stated, I believe that it's important to consider why we are trying to ensure that support for mental health and psychosocial care is available for those who need it. I know that in this webinar, we may be correctly accused of preaching to the converted. And although this is geared to share information and ideas between experts, practitioners in this area, we need to take heed of such criticism and ensure that the importance of this issue can be explained to those outside the sector, so to say. How does this add to social well-being? How does it add to economic development and equity? How does it contribute to equality and inclusiveness and empowerment? And I think we need to refine our narrative in this area, and hopefully this webinar will make some contributions to that. COVID-19 has, as mentioned, in many areas exacerbated the impact of mental stress from a multitude of angles, worrying about the risks of contracting COVID-19 or the family members contracting it, stress from losing one's livelihood, and from needing to use your saving just to get by. stress from isolation and marginalization, and increasing the digital divide. And this is one reason why this webinar is very timely. In addition, there's no coincidence that today is the International Day of Persons with Disabilities, celebrated by the UN and globally, for which the theme is Building Back Better towards a disability inclusive and accessible, sustainable post-COVID-19 world. That's a long word. But our webinar aims to contribute to this dialogue and support it from a disaster risk reduction and climate resilience perspective. In addition, we are in the middle of the 16-day action campaign by the UN Secretary General's Unite initiative to end violence against women, an important issue and very relevant, as we will hear on this issue today. And please, as I am, wear something orange to show your support for this initiative. But reverting back to our topic today, how does mental health and psychosocial services accessible to all that are in need? Well, it's a huge task in countries with a strong health service system, not to mention for countries with much weaker and fragmented systems. So where to begin? Well, it's very daunting. At national level, there is often a need for recognition of the value and the importance of mental health and psychosocial support vis-a-vis other aspects of health, epidemics, maternal health, etc. And they're all competing, so to say, for priority and financing. And at the local level, there is need to ensure that the systems, the capacity and expertise is available, which requires financing and competence as well. And this is a tall order in many areas, as was just highlighted just earlier in. So I hope this webinar will delve on the issues around how we can improve the capacity to provide mental health and psychosocial support. If there is a lack of competent practitioners at the local level, is that due to the lack of competent graduates, leading to an assessment of the educational capacity? Or is it due to a lack of incentives to go into the sector? Low salaries, lack of promotion opportunities, lack of recognition for one's work, etc. Or is it something else? And before deciding on how to address these issues, a good understanding of the issue is needed so the proposed solutions will be effective. Although the impact and consequences of COVID-19 are immense and catastrophic, and for many families and communities, there is, as always, in the context of great disruptions, an opportunity, and in this case, to change how we deal with mental health and psychosocial support. As communities and countries are recovering, how can mental health and psychosocial support be part of the recovery to ensure that the potential can be realized? As mentioned earlier by Ananda, there is a recognition, but how can we translate that into action? Can we portray how a system of mental health and psychosocial support will bring tangible and measurable benefits to the communities and countries? Can we quantify those benefits in both in social and economic context? Today, we will learn from practitioners on how they coped with the onslaught of COVID-19, complicating and worsening many aspects of mental health through increased stress and uncertainty. And it would be my small wish out of today's discussion, seeing a few insights on to the how can be distilled, and ideas on how we can better project the importance of mental health for a balanced and prosperous society. Positive messages of benefits are important in this age of rising divisions, inequity, aggressive social media sometimes, and fake news. I do believe in seizing the opportunity and look forward to continue to engage in this important area. And I wish us an interesting and informative webinar, but most of all, I hope we will be inspired to do better and achieve more in this area. Thank you for your attention.
Thank you so much, Hans, for that very good message. We'll have another speaker for us to welcome and share his insights on MHPSS during COVID-19. Please welcome the Department Head and Director for Center for Crisis Psychology, University of Bergen, Norway, Professor Jarle Id.
Well, hello and thank you. It's nice to be with you and to take part in this very important event. I'm speaking to you from Bergen, Norway. Outside it is snow at the mountains, and we are approaching the winter time and the holiday seasons. But we're also approaching this, or we are in the midst of the second peak of the COVID-19. So this seminar is very timely and of course very, very relevant for us as well. Focusing on mental health in emergencies and the need to invest more and to improve the investments and to achieve greater access to services is a very core topic. So I'm very pleased that you have set up this webinar. I think the year 2020 has been a year of disruption, a year of transformation, and a year of great personal sacrifice for many people and communities. This pandemic has really showed us that the world is a small place, and we are all in it together. There is not really many places to hide. Here at the Center for Crisis Psychology, we have three core focus areas. One area is how physical illness impacts mental health. And the pandemic is a true example of that, how a virus, of course, is not only a virus, but it has so many other consequences, impacting families and lives, and also taking away lives. And that is our second focus area, is the area of grief and complicated grief, and the meaningful aspects of grief as well. How can you bid farewell to the loved ones in the midst of a pandemic, where you are restricted on how many people will attend the service or ceremonies, and you are also in the risk of catching COVID yourself if you attend. There are so many dilemmas and so many difficult choices to adhere to. And of course the pandemic, and to receive diagnosis or being quarantined is a traumatic experience for many, that you are confined and you are restricted in your movements, etc. So this situation we are in the midst of has really drawn the attention to the UN Sustainable Development Goals also, that to achieve and to build a sustainable future and to have greater access to mental health services, there is really a need to improve and to invest more in this important area. Here in Bergen, our investment this year has been in the students and in the psychology program, in training the young students to become more aware and to also engage more in the future that will come. Because I believe that we will not go into the same as before. There will be another future. Perhaps, hopefully, it will be a better future. So building back better is really an ambition that we also should keep in mind. There will be a vaccine available, or and of course there will also be opportunities. So I hope that we also during this day will touch upon what long-term implications this experience will have, and perhaps we now finally see that mental health is put on the global agenda, and that is what we are hoping for. So I welcome you all, and we are very proud to be part of this seminar, and I will leave the word back to you. Thank you, Yvonne.
Thank you, Professor Yarli. It's really very important. Now we have to train our students for sustainability. They will be, or they are, the next generation. To inspire us not to leave anyone behind with his talk on mental health and psychosocial support of prisoners in the context of COVID-19, please welcome Program Director for Global Health, Faculty of Public Health, Thammasat University, Thailand, Professor Dr. Mark van der Putten.
Good day, everybody. I was pleased when I was asked to talk about an often forgotten group. And so I'm going to have a very brief address about prisoners in context of COVID-19. The promise of the 2013 Agenda for Sustainable Development is to leave no one behind. However, there are significant groups of people who are at risk of being left behind. One of these groups are the 11 million prisoners globally. COVID-19 has highlighted their widespread neglect. Prisoners' right to health is often compromised. Although the standard minimum rules for treatment of prisoners states that prisoners should be offered equal health services as those available in the general population. Mental health problems are especially prevalent in prison populations, often because prison serves as a dumping ground for people with severe mental health disorders. And those with substance issues are sent to prisons instead of treatment centers. Further, prisons are bad for mental health. Overcrowding, violence, forced solitude, lack of privacy, collapse of one's social networks, the lack of meaningful activity, uncertainty about one's future, and stigma following incarceration are some of these factors underlying and undermining mental health. COVID-19 poses a threat for prisons, creating fear and pandemic among inmates, as illustrated by the reports on prison riots over COVID-19 in Colombia, in Italy, in Indonesia, Lebanon, and in Thailand. From the onset of the pandemic, various global actors have been calling for attention to prison settings in context of COVID-19, and to name a few, UN High Commissioner for Human Rights, the World Health Organization, the Interagency Steering Committee on Emergency Responses, the Human Rights Watch, the Open Society Justice Initiative, even the Lancet. No, notwithstanding the pleas of these global actors, many outbreaks of COVID-19 in prisons were reported in Africa, in Asia, in Europe, in the Middle East, in North America, and in South America. Quite a number of countries in South and East and Southeast Asia reside in the world top 50 largest prison systems. Throughout the region, prisons are overcrowded, inmates are arriving with underlying health issues, and the lack of resources, especially in terms of healthcare, are common. These conditions create a breeding ground for infectious disease outbreaks. So controlling COVID-19 presented a real challenge in several of Asian prison settings. The riots among inmates in Indonesia and Thailand illustrate fear and panic created by the COVID-19 threat among inmates in Asia. COVID-19 control measures in Asian prison settings present a mixture of front-end strategies, such as alternatives to incarceration, or in-prison mitigation strategies, such as screening and zoning and personal protection, or back-end strategies, such as early releases of elderly inmates and those with low risks for society. However, control measures need to include psychosocial support efforts. This lesson was learned in Thailand, where over time inmates were provided with health information and guidance on self-protection, and the means to do so, such as the supplies of sanitizers and soaps and masks, as well as daily visits as a replacement for suspended family visits. Although prisoners are too often left behind, regionally there are some beacons of hope. In addition to this forum, the ADPC's periodical conference of MHPSS in Emergencies, ICRC organizes annually the Asia-Pacific Regional Conference on Prison Health. And in collaboration with Thammasat University in Thailand, they offer regional and national courses on prison health. Whereas Thammasat University established a prison health research unit aiming to serve prison settings in Thailand and the region. Each of these initiatives offer a platform to address mental health in prison settings. In summary, the COVID-19 outbreaks among inmates have highlighted the challenges in prison management throughout the globe. Reports on prison riots point to the fear and panic among inmates and illustrate the need for psychosocial support at times of crisis. I would like to see that advocacy efforts on mental health aspects of crisis mean something, not only to politicians and practitioners, but also to prisoners and other detainees. Thank you.
Thank you so much for that very informative talk, Dr. Mark. So we're learning much from all our first three speakers, and we now go to our next session. UNFPA Myanmar has been working with a lot of amazing mental health and psychosocial initiatives in the region, and this is one of which we could truly learn from. Please welcome UNFPA Ms. Eri Taniguchi to talk on integrating mental health and psychosocial support and gender-based violence during COVID-19, the Myanmar experience. Take it away, Eri.
Thank you very much. Good morning and good afternoon to everyone from Myanmar. Thank you so much for giving us this opportunity to share our experience in Myanmar for integrated approach to mental health and the psychosocial support and gender-based violence during COVID-19. So let me first start with a brief introduction of UNFPA, as we are not necessarily a big UN agency. So maybe, not all of you are aware about our interventions. So we are UN Sexual and Reproductive Health Agencies, and we are contributing to achieve 3 zeros: 0 preventable maternal deaths, 0 unmet needs for family planning, and 0 gender-based violence and harmful traditional practices. In Myanmar, we have been operating already for long years, and now we have the 4th country program agreed with the government of Myanmar for the period of 2018 to 2022. Under this country program framework, we also have mental health and psychosocial support strategy with key 3 pillars. The first is policy and advocacy to really contribute towards conducive policy framework for MHPSS. The second is building institutional sustainability by providing different capacity building and also supervision systems at the national, state, community levels. The third is technical leadership for quality services, so that we work with our partners closely to ensure quality MHPSS services as part of the overall sexual and reproductive health, GPP, and the youth programming. I think, just to give background why we need to pay attention to GPP and the MHPSS during COVID-19. I think many of us have already heard about the news or like articles that there is an increased GPP risks during COVID-19 because of so many different risk factors. UNFPA at the global level, we also did a projection how much risks of GPP would increase during COVID-19. And as per this projection, there would be additional 15 million GPP cases for every 3 months of lockdown at the global level. As we all know, MHPSS is a key component of GPP case management service, and it is very critical for healing, empowerment, and the resilience building of the GPP survivors, even during COVID-19. We are also observing widespread anxiety among the people due to COVID-19. We conducted crowdsourcing survey with young people in May this year. We received more than 200 respondents for this survey. And most of the young people really expressed that they feel constantly worried and stressed in this challenging situation And some of them even disclose that they have a severe degree of really like distress. We are also observing heavy workload on frontline workers, those working at the quarantine centers, humanitarian workers. Through different occasions that we interact with these frontline workers, we really witnessed signs of stress and anxiety also by the service providers in this challenging context. So all these points highlight that there is a need of addressing GBB and the MHPSS even more so during COVID-19. But the overall resources tend to be really shifted and focused on responding to the overall health crisis, which is COVID-19. And we are facing a challenge of reduced availability and accessibility to critical GBB and MHPSS services. We would like to share some of our initiatives, how we are addressing GBB and MHPSS in this context. But we will also go back a little bit for the pre-COVID-19 time, what we have initiated, because also our response during COVID-19 really evolved or developed on our pre-COVID-19 time interventions. So the first one is MHPSS minimum standards for GBB intervention we developed, especially for our GBB partners. Our GBB partners implement different types of psychosocial support activities as part of GBB programming, but we really wanted to understand better what these psychosocial support activities are, how our partners are really defining the needs of MHPSS as part of GBB programming, and how they are training and mentoring the staff on MHPSS. So we conducted psychosocial support assessment for our GBB partners in 2019. And this assessment really indicated that there is a need of having standardized definitions, terms, and the tools in terms of MHPSS for our GBB partners. Because sometimes people use counseling, but it's not necessarily clinical counseling, but it's more used as counseling as part of GBB case management, etc. So this assessment led to the development of minimum standards. So the main aim of this minimum standard is really to establish a common understanding of what constitutes or what is required as minimum MHPSS activities under GBB programming. So you can see this, the drawings below. So I will not go into the details, but we also categorized what type of MHPSS activities can be provided by what types of service providers as per the IASC MHPSS pyramid for different layers for GBB programs. We also included key guiding principles as well as definitions of key MHPSS terms and the different service providers in the minimum standard, and then set the suggested activities as per community-focused MHPSS and the case-focused MHPSS. Another example is MHPSS Peer Support Network. This one also, we started the first peer support network in Mondo in Northern Rakhine in 2017. And we expanded this peer support network, and we have now additional 2 networks, also in Sitwe in Rakhine State and also in Michina in Kachin State. So these peer support networks really aim to improve skills to respond to MHPSS needs of GBB cases or GBB survivors, and also to better manage complex cases. Also to enhance and facilitate referral pathways among agencies as part of the peer support network, and also aiming to contribute to the better staff well-being. So this peer support network usually organize monthly or bi-monthly regular meetings among the members, and provides a safe space for frontline staff, mainly GBB, but also some other protection workers, to share their feelings, also some challenges and experiences in managing MHPSS needs. During COVID-19, we shifted this support network to online weekly meetings in one of the locations, and really focused on addressing staff well-being and the self-care for frontline workers. During COVID-19, we also provided a series of different GBB MHPSS online training. In order to provide timely and quality technical support to our partners, we established the MHPSS roster team in mid-May, composed of 4 national experts under the 1 international MHPSS specialist. And so far, the team provided training over 1,500 persons, mainly service providers. And through this online training, also the partners really understood and realized the importance of having, improving basic MHPSS skills by GBB service providers, including hotline or helpline staff, and also by the COVID-19 quarantine center volunteers. And we contributed to further capacity building of frontline staff. Now we are also seeing that with this increased recognition of this importance, we see an entry point or more opening to shift from this short-term COVID-19 response towards longer-term capacity building and the more systematic integration of MHPSS as part of GBB programming and the services. So this is one of the opportunities actually which was opened by COVID-19 pandemic.
Okay.
So this is, I think just to show some quotes from the volunteers who attended the training, that they really also, they were feeling a bit also like stressed and anxious by every day supporting the people at the quarantine centers, but after by attending the training, they are now better able to support themselves as well as those who are at the quarantine centers. So some of the challenges that we have faced. So of course, with the COVID-19 restriction measures, we really had to shift quickly to remote and the online GBB and MHPSS service provision, even though we provided extensive technical support, but also because of the movement restriction, I think we really also face a challenge that we cannot provide full-fledged supervision and the monitoring to ensure service quality. The less priority is given to GBB and the MHPSS overall vis-a-vis the COVID-19 response. So we also try to address this challenge by integrating this GBB MHPSS into other health-related activities. For example, integration of key messages with distribution of hygiene items, which is more prioritized also by other actors. While there is also a need for capacity building to adapt to the new situation, but everyone is so busy with the COVID-19, so limited time is available for capacity building. So this also necessitated us to combine and further integrate GBB and the MHPSS so that we can just provide as a one package for the capacity building. And the last one.
Yeah, okay, last one now, Erin, right? Okay.
Yeah, I think the last one is also a bit more technical. So I think now we are shifting to online training, and we have to be innovative. But sometimes it's a bit difficult to make it fully interactive and participatory. So this is the last slide for call to action. So yeah, really, like, we would like to emphasize that the GBV and the MHPSS should be an integral part of COVID-19 response and recovery efforts, and the continuity of these critical GBV and MHPSS services need to be really prioritized by all the actors, which would contribute to ensuring overall well-being of the people. And the GBV and the MHPSS services are complementary and reinforce each other. So there is like a mutual benefit of having integrated approach. And lastly, but not least, we really need to pay attention to self-care, staff care of GBV service providers, frontline workers, COVID-19 response staff. So yeah, this brings me to the end of my presentation. Thank you very much.
Thank you very much, Eri. And we all know that GBV and MHPSS services are complementary and should reinforce each other. Rolling on, Philippines is one, if not the first country in the region to come up with an integrated, comprehensive MHPSS contextualized law. To share with us MHPSS and COVID-19 from policy to practice, please welcome Chief of the Preparedness Division, Department of Health, Philippines, Dr. Ronald Lau. Take it away, Ron.
Good morning, afternoon, and evening to all viewers and listeners. First off, thank you ADPC for inviting the Philippines here. I'll share our mental health policy and our COVID experiences. So I hope this can add value to our discussion on improving MHPSS response, not only to COVID, but to other emergencies and disasters as well. Our history goes back to the 1991 Mount Pinatubo volcanic eruption, when the government thought it logical to deploy teams to provide psychosocial support to affected communities. In the years after this, natural disasters, especially typhoons and floods, became more frequent and intense. In 2008, the Philippines adopted the IAAC guidelines and started the MHPSS program, with yours truly as the first program manager. During this time, we have managed to include this in our disaster management policies and framework, and a separate cluster was devoted to it. The turning point was in 2009 when Typhoon Ondoy, the worst typhoon and flooding to affect Metro Manila, happened, killing many Filipinos. This is when MHPSS was popularized in response. We made significant progress in the program through capacity building, networking, and a lot of response, learning from them. And then in 2013, Typhoon Yolanda, one of the worst disasters ever recorded, hit the Philippines. MHPSS, I could say, was an integral part of the response then, with the magnitude of the devastation. The game changer, though, was the passage in 2018 of our mental health law, which really galvanized our commitment to mental health. Little did we know that another kind of disaster, a pandemic at that, will happen in 2019. As we do our COVID response, MHPSS is one of our important services. In 2018, the Philippines was able to pass our mental health law. You can see here the happy faces to celebrate this milestone. We are proud of this because of the following. This was informed by our disaster experiences. So all that we learned from responding to many events were put to good use. This was based on global guidelines and universal principles, but we adapted it to our setting. For instance, spirituality was tapped to be an important aspect of our coping and resilience. This would not have materialized without the support of our lawmakers, the WHO, UNICEF, other INGOs, our health colleagues, the academe, NGOs, ADPC, advocacy and interest groups. So all partners and stakeholders really work hard to make this happen. It was something that was long overdue, and from the day it was passed, all All that's needed to be done is, of course, to implement it. In our Philippine Mental Health Act, we want to do the following. Strengthen leadership and governance. This is key. Develop and establish a system that's comprehensive, integrated, effective, and efficient. Protect the rights and freedoms of persons with these needs. This is pretty strong in the policy. We have to firm up information systems, evidence, and research, without which we cannot make sound policies and plans. Integrate mental health care in basic health services and make it available in different settings, not only in primary care and hospitals, but also in educational institutions, the workplace, and in communities. We're all guided by this in our strategies. Moving on to psychosocial impacts of COVID, I'd like to share a recently published study of our group on the psychosocial impacts of COVID on adults. From 4 continents and 8 countries, which include the Philippines, we surveyed more than 8,000 plus adults from May to June of this year. We look at how the psychological response to the pandemic varied across different countries and identified which protective factors contributed to this. Probable GAD, generalized anxiety disorder, and MDE, or major depressive episode, were indicated by 21 and 25.5%, or a fourth of the respondents. In terms of factors, the strongest association is with what we call the sense of coherence, or SOC, or basically the coping capacity of people to deal with the everyday life stressors. You can see here how the Philippines fares in comparison with other countries. So this is just the tip of the iceberg. COVID-19 and mental health impacts are something that we should look into. In responding to COVID, we are doing the following strategies. We develop policies and guidelines aligned with IASC and our national guidelines to provide the needed direction. To do coordination, we organize virtual meetings with implementers and partners to discuss challenges and, to strategize. We have webinars on the impacts of COVID to promote a better awareness of the various issues. To reach out to Filipinos, we post social media and different materials. So helplines are also useful. It allows us to reach out to callers to manage their concerns. We put up a one-stop shop in our airport to assess returning overseas Filipinos. We also monitor our quarantine and isolation facilities for MHPSS needs. As is routine, we conduct MHPSS services for different target age groups, different target groups for that matter, and we're pleased to share these good practices. A mapping study of our MHPSS services during COVID shows that government, private sector, and NGOs are providing complementary services just to reach out to all Filipinos. We're covering the general public, medical frontline responders, individuals who got COVID, and the vulnerable population, elderly, children, pregnant women, persons with disabilities. So most services relate to information dissemination through online means and psychosocial support for staff and volunteer frontliners. So recommendations are pointing towards more offline or face-to-face strategies. It also says that non-medical frontliners should also be given equal attention. The study also cited the need for clear coordination and MHPSS being part of general health services. So we're looking into all of this to improve, of course, our response. These are challenges we're facing. Multifaceted issues brought about by the pandemic, lockdown effects, distancing, staying home, infodemic, economic and job losses, a changed work, life, and school arrangements, a fear, anxiety, stigma in health workers, and those who are positive, the impacts of other disasters. So the sheer demand for MHPSS services naturally increased. So these challenges our ability to provide the services, the manpower, and the way services are being delivered. The pandemic response is so focused on response to the virus, to the disease, that MHPSS can easily be sidetracked. So we need to make this a priority. Health services were also disrupted, and this also affected the delivery of mental health services. So health workers got infected. Some of them even died. The fear, anxiety, stigma were so high that the people who are supposed to provide these services needed the services themselves. So this also affected the supply chain, availability of psychotropic meds, referral systems. So the persistent challenge of integrating mental health in primary care again came out. If we had this in place in most parts of the country, before COVID happened, things could be much easier to handle. These are lessons we're learning. First, the ever important role of coordination to cover more ground, to reach out to more Filipinos by working with as much partners as we can. The whole of society approach is really a major requirement. In spite of the mental health law and all the nice words written there, being 2 years of age only, much still remains to be done. We should work harder to make it a reality. In the new normal brought about by COVID, we need to adapt and innovate. We have tried virtual platforms, telemedicine, we have used social media. In the discussions about resilience, mental health is always there. But we know that more needs to be done to promote and provide MHPSS services at scale. We are considering all of this in our special initiative on mental health, which is basically a strategic plan to help us capitalize on good practices and find out solutions to address all of these challenges. In the Philippines, we need to sustain our gains. We need to do a lot more to implement our mental health law and improve our programs in MHPSS. So we believe we can work with you in these areas, which are the following. We need to jointly develop and implement important guidance documents and standards. We need to share good practices through fora and webinars like this. We hope we can engage with you on research and maybe in simply documenting what works, what not in different places. And finally, we are biased towards this capacity building. So we need to put all the investments here. So because we still need to have this critical mass of people who have the capability and expertise in the various modalities needed for MHPSS. And we really hope you can help us on this one. So let's continue hoping and praying for the best out of this pandemic. And may all of our experiences be turned into opportunities to really build better in the new normal. So on behalf of the Philippines, a country most often affected by disasters, but one whose people are one of the most resilient breeds there are, thank you, maraming salamat at mabuhay.
Thank you very much, Dr. Lau. So integration, coordination, collaboration, multi-stakeholder, whole of society approach is the way to go. Rolling on, tourism is the major industry in Thailand. And although the country is recognized to have contained the spread of the virus, small to medium-sized businesses have suffered economically. To share us his personal experience on MHPSS of small to medium-sized entrepreneurs in Thailand during COVID-19, please welcome owner of Ving Thailand, Mr. Wati Witchanit. Take it away, Kun Wati.
Good afternoon, ladies and gentlemen. Can you hear?
Sure ka.
Okay. Thank you so much for the invitation of ADPC and MHPSS to let me share my experience about how I can manage myself and my business during COVID-19 pandemic. I'm the founder of Ving Thailand, the first marathon running and recovery flip-flops with ankle lock strap in Thailand. So my product is quite special. So as you can see, my product is for sport. So my main market is outdoor running and running race events, which have thousands of people involved. I started this Ving business since September 2019, just 4 months before coronavirus started to spread in China. I think you can imagine how the virus affects my business. Actually, I never concerned about the COVID-19 before. And many times I laugh for people that were to panic about the virus until my condominium has an infected case. And there are many cases nearby my area also. After we know it, I also panicked too. Me and my wife were really nervous and we went to stock food and supplies and buy a lot of overpriced face masks also. My wife got vertigo and dizziness, which never happened to her before. So we thought that she got the virus. So we go for virus testing also. And we were lucky. She was just too straight about the situation. So, and then after the lockdown began, the real problem came. All of the running races were canceled. People were not allowed to go outside for workout activities anymore. And most of my customers and other people panic and buy only face masks and alcohol gel. No one care about workout. And I cannot go to meet my supplier or distributor or join any running event race anymore. So what did I do to cope with the situation? As I understand, fearing can be controlled by knowledge. So I just study about the virus to protect myself and my family and share to my network, my friend also. When we stay at the home, it makes us stay, so we do a lot of challenge online on the social network also, such as cooking, and we did a lot of cooking menu while the lockdown period. For business, in January, after the virus started to spread in China, I was quite lucky that I consult with the manufacturer for new material that can protect from bacteria and launch a new product model with antibacterial features in February. It cannot prevent the virus, for sure, it cannot prevent, but it works very well with the customer emotions because everything that makes something more clean can be sold. So I can still continue selling my product also while the period. When the lockdown began, I stopped for initiative for my business. When the lockdown began, I stopped all the future marketing plan because it cannot be used anymore. And then I did financial health checks to reduce unnecessary spending and looking for another options for income, such as getting a personal part-time job also and another income. Other than that, I promote a new promotion to give free furbished mask for every pair of flip-flops with my own brand, so I can continue promotion. I focus my marketing channel to be online because online is the only way. I created a lot of Facebook contents to support about workout at home and self-protection. I'm quite an optimistic person. I always look for the positive side of any situation for this pandemic. Even during the lockdown period, I thought that people need to make themselves stronger. So this virus make people realize that they need to improve their health immunity by workout. So everyone want to work out more than the pandemic. So my vision was, after the lockdown, sport product with reasonable price will be very popular after the lockdown. And I quite lucky, I was true. Domestic market is good again because it's hard to import product and people want to save their money also. So the last month of the lockdown, I predicted that people will be very stressed, bored, because they have to stay at home too long. The only thing they can do is shopping online. And there's a lot of box in my house also. I'm lucky again that it was true. My antibacterial model is the most selling product ever. So the last month of the lockdown, in May, I made a new high for 100% online sales growth in May. So really cool. Okay, let's summarize. From my experience, first thing, we have to always looking for a positive side of any bad situation, but still live with the reality and moment. That's really important. The new normal, so just it's the new normal. We just accept it and live with it. The good thing is the COVID-19 saved Thai people life for 56% from Songkran Festival. Before it's like a 386 the last 2019, but this year just 167 people died from Songkran. So it's more than the COVID. We have only 60 people die from COVID-19 here. It's the new normal, so just accept it. It's a good time to change because many companies can transform in this period. And the last one is the online is the only way to survive. So we just looking for the new next normal and do it first. That's all.
Thank you so
maybe
much.
Too short for everyone.
Yeah.
Hope this help.
Thank you so much, Kunwati. Kapun ka.
Kapun kap.
Use your fear to create new products and marketing plan. Be positive and think positive. Be optimistic. Children is one of the vulnerable groups affected during COVID-19. Schools were closed, physical distancing, and lockdowns were strictly required, which had obvious impact on children. To share the effect of mental health of children in Vietnam during COVID-19, please welcome the Director for Center for Information, Service and Research in Psychology, Vietnam National University, Dr. Dang Quang Minh. Take it away, Minh. Sound. Please unmute your mic. We can't hear you.
You hear me now?
Okay, now, okay, okay.
Okay, so also you can share the, you can see the screen?
Yes, yes.
Okay, so thank you very much for inviting me to the important event. So I'm Minh, I'm from Vietnam, and I'm a clinical psychologist, child clinical psychologist. So that's why I will talk about the mental health, the effect of the COVID-19 to mental health of the children. So let me begin with the context of the pandemic in Vietnam. So from January to May this year, the school in Vietnam closed. And from 20 April to the 10th of May, so it really the confinement in Vietnam. So very the strict confinement in Vietnam. And so from 10 May, the school opened again till the end of the school year, mean that in July, 1st July. And so everything was fine until 26th of July, where we found cases in the hospital in Da Nang. And so then from 26th July to 20 August, so it's the confinement in Da Nang, and with 35 deaths in Da Nang. So it was the first cases that of the COVID-19 in Vietnam. Before that, we haven't had any death. And so after 20 of August, on the 5th of September, so the new school year start again, and the school open. It's 2 weeks later than previous year, and from September until 3 days ago, we didn't have any new cases in community. But the latest news is that on the 30th of November, so we found 1 new cases in the community in Ho Chi Minh City after 89 days of no cases in community. So now it's really also we don't know what happened in Ho Chi Minh City, because from this 1 case we found another 4 cases, and also about 500 F1 of this person. So we don't know what happened, and some of the schools in Ho Chi Minh City closed again now because of that. So of course, with all that difficulty of the COVID, so there's a great impact on children mental health and well-being. So a review of study on the impact of COVID-19 on children show that there's an increase in depressive and anxiety symptoms in adolescents and children. And so most of the study is from China. And so another study review show that the nature and extent of this impact depend on several vulnerability factors, such as the developmental age, educational status, pre-existing mental health condition, or being economically underprivileged, or being quarantined due to the infection or fear of infection. And the pandemic and lockdown have a greater impact on emotional and social development of young children and adolescents compared to that in the grow up. And the school children answers regarding cancellation of examination, exchange program, and academic event. And young children show more clinginess, disturbed sleep, nightmare, poor appetite, inattentive need, and significant separation problem. And the children and adolescents having special needs. So for example, children with autism, ADHD, or the physical disability, learning disability, or developmental delay, or other behavioral and emotional difficulty encounter challenges during the current pandemic and lockdown. So for example, they are more difficult in following instruction, understanding the complexity of the pandemic situation, and doing their own work independently. And children in quarantine, of course, have more feeling of sadness, anxiety, fear of death, fear of parent death, and fear of being isolated. So that's the review in the world. So in Vietnam, recently UNICEF released a report on the impact on children mental health and being in Vietnam. So it's a rapid assessment on social and economic impact on children and family in Vietnam. So the report state that many people, especially those in rural area and ethnic minority, fall into poverty due to unemployment, underemployment, or loss of income. And so it looked more serious in the rural area than the urban area. Also, the difficulty among poor and near poor households were exacerbated, and the access of family with children to routine maternal and child healthcare service were higher. And healthcare facilities, so such as hospital, overwhelmed with work to control COVID-19 transmission. So regarding mental health, the report states that there's more risk for children experiencing or witnessing violence, exploitation, and abuse. And so, for example, the Vietnam Women Union reported double of the number of newcomers to the peace house that a shelter for domestic violence and abuse victims since the outbreak start. Also, the study found that 3.4% of interview participants report that children face physical and verbal violence from adults in family. Also, online learning. It was a solution for education, but the distant learning modalities, for example, online, TV, radio, or pose the challenge with respect to ensuring inclusive and quality of learning. For example, online learning compound inequality in education for most disadvantaged group, especially children with suboptimal socio-economic background, for example, ethnic minority group and poor family due to the digital device and literacy. Also, teachers, especially in disadvantaged area, were not well prepared to facilitate online learning. And for example, 93% of teachers in remote provinces reporting not having used modern technology in class prior to the COVID-19 crisis. And the lower educated and poorest family were less likely to access internet and digital devices, nor did they have workspaces, book, or other learning material at home. On mental health, so in the report, there's also the report. The UNICEF report the increased stress, anxiety, and depression among children. Children of primary school and above age tend to confront more mental and psychological health challenges than kindergarten age children due to the distinct awareness of their surrounding. and children was either exposed or at risk from violent and mental health challenges, and also risk for experiencing or witnessing violent exploitation and abuse. However, the children in that study also report that they participate in decision making at home and be part of the family in discussion of the situation. So the current support children during the COVID-19 of the Vietnamese government is that, first of all, we have the financial relief package by government for family in needed, and so many children in the family, poor family or near poor family can have that support. Also, in some facilities, the MHPSS intervention pyramid was implemented. However, we observe that most of the organization and agencies focuses on the first and the second tier, so the two basics tier, not the third and the fourth one. Also, the community and neighborhood support were really a big support for people and also for children in the community. Also, the online information on MHPSS in COVID-19 was very various and abundant. So, for example, you can see their manual also developed by, for example, my school and or in MOET, Ministry of Education and Training, like the manual to support mental health for students, college students, and also with the support of ADPC, we also organize a network, technical network in Vietnam, who were the alumni of ADPC training on MHPSS to develop the manual for mental health support during the COVID. Also, there's also the support from UNICEF, for example, for the research that I mentioned, but also from UNICEF work closely with the Ministry of Labor and Social Affairs to develop the MHPSS guideline training curriculum for child social worker and child protection staff to promote the third tier intervention. And so the recommendation is that really the mental health need to be integrated and incorporated in disaster management and health sector. So, for example, currently there are no mental health support in quarantine camp. So, and we heard of through the news and press that, for example, when the children was in the quarantine camp, they have no mental health support, and also they show anxiety and anxious, and there was also reported that there are one or two cases of suicide from the quarantine camp. And also the three-tier MHPSS pyramid recommended by IISC need to be promoted, because currently, as I mentioned, the first and the second tier were well organized, but not the third and the fourth one. Also recommended that we should launch and implement the MHPSS program, including the early identification, counseling, management of children with mental health and psychosocial problem, and especially those at risk of victim of violent abuse, as well as frontline health worker and teacher. The fourth one is that work with the Ministry of Education and Training to prepare school and other testing to provide MHPSS services to address stigmatization and discrimination. And also here, prepare school means that all teachers need to be involved in the MHPSS, because recently when we work with school, and the Ministry of Education mentioned that they only train the teacher who are in charge of counseling service to do that, but not all the teacher. But we really think that in case of disaster, all teachers need to be involved. And the last one is really we need to coordinate services between different sectors, for example, health, social affairs, education, and also disaster preparedness and management. So the last slide is really the propagandization in Vietnam. So we have that a picture everywhere. So to invoice the message that really COVID is really the enemy of Vietnam, and so all the measures need to be strictly applied. And so that was why COVID-19 is now is quite under control in Vietnam. So thank you for your listening.
Thank you so much, Dr. Min. So integrate MHPSS and look into the IASC pyramid. Children are exposed or at risk from violence and mental health challenges. Therefore, allow them to participate in co-discussion in the home. So I think we have several questions. We can only take maybe one or two at this point. However, because we have some more interesting discussions following, however, please continue to write your questions on the chat box, because we are sending right now to our speakers, and they are answering them accordingly. So I think I have one question here. I'm not sure if this is from Dennis of the Philippines, and this is for Eri. So he says, Eri, COVID-19 has made millions of people in turmoil. What specific activities show staff well-being and self-care in workstations in Myanmar? Eri?
Yes, thank you. Thank you for the question. Of course, like different organizations, provide different support system, especially for the staff. Just to briefly mention what we have been doing as a UNFPA Myanmar. So fortunately, we have this one international MHPSS specialist who is clinical psychologist, as well as we have national roster team member with us. So I think from the early time of the COVID-19 pandemic, we also organized the internal learning session for UNFPA Myanmar staff by the specialists, how COVID-19 could impact the mental health well-being of the people, what are the signs, and then like this is normal for everyone to feel in this way, how we can also address by sharing some of the basic positive coping mechanism. So we did this learning session, and we also recorded this session and shared also with staff from other UN agencies, so that they are aware of what is happening and what we can do to address this. And our also teams are also providing like counseling support to our staff, and also staff from other UN agencies as requested if they feel that they want to have one-to-one session. Thank you.
Thank you so much, Eri. I think I see a lot of questions right now, but most of them could be answered after the second session. So probably it's about time to take it away and give it back to Ananda. Take it away, Ananda.
Thanks very much, Yvonne. Now we're coming to the second round, the second panel, the second session of our webinar. And we'll be having 3 speakers. As Hans said at the outset, today we celebrate the International Day for Persons with Disabilities, and mental health conditions and psychosocial disabilities are often unrecognized and inadequately responded to. And indeed, there's often limited attention to the mental health and psychosocial well-being of persons with other disabilities as well. So it's particularly relevant today that we have a panelist who is going to discuss some MHPSS challenges and responses for persons with disabilities during COVID-19. And I'd like you to welcome the manager for specialized trainings and the Disability Resource Center at the Employers Federation of Ceylon in Sri Lanka, Ms. Manik Gunaratna. Manik, The floor is yours. Thank you, Manik. You're sharing your screen, but I'm seeing your email inbox at the moment. Great, that's it. Perfect, thank you, Manik.
Just okay, thank you very much, Sananda. Today is the International Day for Persons with Disabilities. To talk about mental health for persons with disabilities, I think it's you have included a person with a disability, because we always say nothing about us without us. Right. People with disabilities, have to face a lot of challenges, difficulties, and they have to overcome all these mental challenges that they face, especially during COVID-19, because people with disabilities, due to their disability as well, they undergo a lot of challenges due to mental health reasons. So this pandemic has created a lot of mental health issues for people with disabilities. From the Employers Federation of Ceylon, we provide many services for people with disabilities on mental health, especially on counseling. Why is mental health and psychosocial support important for people with disabilities? People with disabilities in in isolation or in a quarantine area, they are neglected, because people with disabilities in the normal scenario, we actually live in a lockdown situation. But when the whole country is in a lockdown situation, actually we are double marginalized. We don't have the way of accessing the resources, the mental health care facilities, health sector, the medicines, everything, because the transportation is not there, the caregivers are not there. So it's very difficult during the pandemic season for people with disabilities. People with disabilities face a lot of communication barriers, because information is not available in accessible format, especially sign language interpretation is not available for hearing impaired persons. So give the information with regard to mental health is very difficult. Again, then due to the separation from family members, there's a sort of trauma, and because people with disabilities, especially people with intellectual disabilities, they don't have the independent living skills. So they depend on somebody, a caregiver or a family member. In Sri Lanka, we had an incident where the mother was COVID positive and she was taken to hospital, and she had a child with an intellectual disability. So it was difficult for him to, bear it up that the mother was taken away and this child was kept at home alone, and this child committed suicide. So it's a very sad situation. So especially for people with disabilities, separation from the families, and even in quarantine centers, for people with disabilities, proper facilities are not available, and especially on mental health, there's nobody to do counseling, talk to them, give them comfort. It's very, very difficult. The challenges that we as people with disabilities, we face lack of counseling, access to counseling. Now, there are a lot of counseling services available, but they don't have the expertise in counseling for people with disabilities. So the information also won't reach people with disability. This is a very big gap that we face among people with disabilities. And these hotlines which give counseling and other support services, sometimes they are overcrowded, the lines are not working. So especially to give the expert knowledge on persons with disabilities counseling, there are no trained people. So this area is very important. Due to social distancing, village support services are not available because the community is not sensitized. If the community doesn't know whether there's a person with a disability who has mental health issues and who needs psychosocial support, because these psychosocial persons with psychosocial disabilities are double and triple marginalized, because due to social stigma and various other reasons, people don't accept them. So therefore, it's difficult during an emergency situation for them to access other resources. And people who are in long-term medication, it was difficult for them to access health services during the lockdown situations. You know, there was no way. The government had some systems to, deliver to postal services, deliver the medicine, but there were a lot of persons with disabilities who are undergoing mental health, who have mental health issues, did not have way of getting all this medicine. All these therapeutic programs, counseling services, due to the lockdown situation, they were not functioning. But sometimes online facilities were given. But the technology, no knowledge on technology, devices are expensive, and also to access these online platforms, the data connectivity, internet issues, all these problems people with disabilities had to face. And also there were a lot of persons with disabilities who lost their job due to this COVID-19 situation. So it was very difficult because one, being a person with a disability, losing a job means the income is not there. So they had to, because due to losing of jobs and mental health issues, there were a lot of people with depression. So sometimes, there were a lot of domestic violence due to this. Sometimes hearing about children who could hear and speak of deaf parents, they used to call and say that the parents are fighting. Why? They have lost their jobs, no financial resources, no money to eat. So there were a lot of domestic violence also going on due to this situation, and people with harassment from the partners, the spouses. So they didn't have way of accessing the counseling systems, and also information doesn't reach them. So actually these issues should be addressed, and this data is not available. So only because we are working for persons with disabilities at organizational level, so we get the information, but at national level, implementation of programs for people with disabilities on mental health is not available. Best practices, what are the best practices that we can implement? These are what we did to organizational level. Communication groups. It's very important to have communication groups so that, where people with psychosocial disabilities are with, to make them inclusive with other groups, so that somebody can assist them and provide them the information they want. Then the buddy system. Buddy system is also important for people with psychosocial disabilities. Especially when there's an emergency situation, COVID-19 is one, or maybe a cyclone, some maybe floods, tsunami. The people with psychosocial disabilities, they are left behind. There's no one to support them. Even though at village level, they don't know that there is a person with a psychosocial disability and also with other disabilities as well. So it's very important that you create a buddy system so that the other peer group support is provided. So there will always somebody to assist them. For example, now maybe a hearing impaired person who is having a psychosocial disability as well. He or she didn't have way of communicating, getting the information. But if this buddy system is there for somebody who knows sign language, could definitely would have supported. So it's important that support networks are created. Then through organizational level, we created a mobile app called Be Safe, that is especially for women with disabilities. I have to speak about women with disabilities also, which gives support for women with disabilities. Because women with disabilities, they don't get information due to communication barrier. It's our right to get information. So this counseling or the support system on mental health is also included in this mobile app, so that women with disabilities who need psychosocial support can get the support from this mobile app. Then the methods to access these services, the data. Data should be available. The biggest barrier in Sri Lanka is we don't have a database at national level. So even at a COVID situation, nobody knows how many people with disabilities need psychosocial support, who have financial difficulties, how to reach them. Because during the COVID-19 situation, government provided 5,000 rupees for people with disabilities, but they didn't have proper data. Most of the majority of people with disabilities could not access these services. And due to that also, psychosocial problems, mental health and psychosocial support we needed. Yeah, about buddy system means to have somebody to support him, a friend, right, from the community itself. Then it's easy for them to support another person with a disability who needs psychosocial support, because that person might not be, if it is a hearing impaired person, he cannot access the mainstream hotlines or the council services. So the person who is the buddy can always access those information and give them. So that's why buddying system is important. Maybe a person with a physical disability, he or she has a transportation difficulty, so that the buddy can always support them, go and get maybe the medicine or get any other support. So data is very important. In Sri Lanka, we don't have proper data at national level. So every time it's very important to have a proper database. Hotlines should be accessible for persons with diverse disabilities. So the hotlines which support psychosocial support, mental health, only they have the audio facility. What about the sign language interpretation? It's very important that video call facilities is given, and person who knows sign language should be there in the hotline. And also people with intellectual disabilities, they have to support them in simple way, because it's not easy for them to grasp everything. And also people with vision impairment, information should be in accessible formats. I always would like to recommend, even at hospitals, for people with disabilities who need psychosocial support, to give them a priority card or some identification similar to that, so that it's easy to access the resources. Because in an emergency or during COVID, everyone is trying to access these resources, and then people with disabilities are left behind. So if the hospitals who are supporting in mental health, if they can identify these people with disabilities who need psychosocial support, if they are given some identification, a priority card or whatever, then it's easy for them. Especially these priority cards are very important. There are some people with intellectual disabilities who need psychosocial support. It's not easy for the parents to keep these people with intellectual disabilities in long queues for long hours. So these priority cards are very important for them. Accessible on online platforms. There are so many online platforms going on, but how many online platforms which provides counseling support or psychosocial support is accessible for people with disabilities? For starting with vision impaired persons. Vision impaired persons either they use a screen reading software, either through the mobile or the computer. So if the website or this platform is not accessible with the screen reading software, they cannot access these resources, these information. And if the person is a partially sighted person using a screen magnifier, so if the large font is not available or the platform doesn't cannot be, the font size cannot be increased, so they also cannot access these platforms in accessible way. If the sign language interpretation is not there, so they don't know what to if the sign language interpreters are also not there, it's very difficult for them to access these resources. In the mobile app which I told you called Be Safe, we have a separate feature for hearing impaired persons to go through a sign language interpreter, and because it's women specific, we have included women sign language interpreters, because women with disabilities, sometimes the problems they have psychosocial, they cannot tell it to a male counterpart. So we have included female sign language interpreters so that they can come out with everything and the counseling support can be provided. In counseling services, I would like to suggest that the counselor should be taught sign language because if a person with a hearing impairment speak to a counselor, and he or she goes through a sign language interpreter, sometimes the correct information might not go because it's go through another person. If all these counselors who are supporting, giving psychosocial support in mental health, if they can learn sign language, right? I am not telling everyone to learn, but at least if you have a small cadre which knows sign language, then it's easy for them to communicate. They will not have any fear because whatever they talk in sign language, the counselor is interpreting, and they will feel very comfortable because they are not going through another person. Because if they go through another person, maybe a sign language interpreter, all their feelings, all what they have to say, have to tell to another person. The confidentiality is not there. Then the takeaway message is that we have done a lot of awareness programs, everything, but let's build back better, at least from today onwards. Nothing about us without us. So thank you for including a person with disabilities to talk about mental health for people with disabilities. If you want to see the work that we do for people with disabilities, you can log on to our blog or the YouTube channel, get any information you want.
Yes.
Thank you very much.
Thank you so much, Manik. We will try and post those links in the chat so that people can access it. The links that you shared on your previous slides, we'll do that. But thank you so much for highlighting a number of really, really important points, both from the sort of the way in which vulnerabilities that predate COVID-19 are amplified for persons with disabilities in the current context, but also how some of the challenges that the general population is facing are especially heightened for persons with disabilities, especially, and I think you emphasize this quite strongly because of the lack of sensitivity to the needs of persons with disability, but also the lack of expertise in the amongst service providers to serve the diverse needs of persons with disability, with different forms of disability. So thank you so much for that, that contribution. I'd like to, I need to unfortunately move on, but it's to another really important issue. So in the context of COVID-19, death, the loss of loved ones, and dealing with grief have been some of the most painful experiences that people have had to endure, especially when, because of the restrictions around the pandemic, affected individuals are not able to, or not sometimes allowed to, go through conventional or traditional grieving processes. And to share with us some of the insights on how to manage bereavement and grief during COVID-19, I'd really like you to welcome clinical psychologist and advisor to the Center for Crisis Psychology at the University of Bergen in Norway, Ms. Unni Marie Heltner. Unni, over to you.
Thank you. Can you see my screen? Okay,
Yes.
can you hear me? Can you hear me?
Both extremely well.
Great. So first of all, thank you so much for inviting me. And I also want to give a great thanks to all the former speakers for their interesting and also very useful input. I really have enjoyed it. So I'm going to talk about the managing of grief and bereavement in this crisis situation of the COVID-19. Now, a famous Norwegian writer has said in a great poem of grief that grief is a very hard material. And I have symbolized this with mountain and rocks. Grief is really indeed a hard material, and it sort of cuts us up inside, because the pain sometimes is so intense that it feels like we are somebody is cutting us, and we are cutting us on these very, very sharp edges. And also grief is a journey through pain. But due to the pandemic, many of us has to make this journey alone in this situation. And the reactions of griefs is, of course, the huge emotional pain and longing experiences in painful waves. So at first, the wave is very high and the pain is very intense, almost so we cannot differentiate between good and bad, because everything is bad. And gradually we start to fluctuate between the pain and everyday life. And this is dependent on distractions. We will experience lowered mood. Rumination is a very, very central part of grief. Feeling of guilt comes whether it's rational or irrational. Many will experience sleep disturbances, reduced concentration, loss of energy, loss of hope and meaning. Depression is a very high risk. And some will also experience trauma reactions because they have lost their loved ones in very, very dramatic or very painful, impressive situations. And in children, of course, the reactions are related to the developmental level. So coping with griefs, the most central help in grief is social contact and social support. So we need to have presence and close contact with each other, and also with the ill and dying persons during the illness and moment of death. And this is taken away from us in the current situation. And now in Norway, we have had closed down and opening up and closed down and opening up from the 12th of March. But what we have had all the time is very, very high restrictions of visiting the practices in the hospital wards and in the caring home for old people. And in periods, every contact, every visit have been terminated. Nobody can visit. So we have had situations when people have been dying alone all along since March. And we have had situations where the relatives, the close ones of the person dying, would have to divide between them who is going to be close, who is going to be present, because they can only come 1 or 2 persons at a time. And we also have seen that even if the authorities, the health authorities have said you have to be flexible, you have to use common sense in this situation, we have seen that the restriction has been very rigid practiced all over, because the management of the institution has been so afraid of starting a wave of contamination inside their wards. So, and rituals after that, taking care of the dead body, for instance, being able to see the dead person one last time and maybe have a sermon in relation to that, as well as the burial ritual. All of this has been restricted and sometimes impossible to accomplish. So the rituals before the funeral, where the families and the friends comes together and sort of prepare for the funeral to come the day after, has been taken away. And also the important social contact during and after the funeral. You want to hug, you want to hold somebody's hand. For children, it's so important to be able to sit on a lap, to be somebody holding around them. And every aspect of this has been taken away. So social support after the funeral and the week and months to come has been restricted to telephone calls or Skype meetings. And we know, in the Norwegian context, we know that the attention of the bereaved from the friends and relatives tend to be reduced during the months to come after the grief. So the grief lasts for much longer than the attention and the care lasts. And in this situation, where we are prohibited to see each other and be in direct contact and meeting, the attention will get even lower and harder to stay. And of course, activities and distraction is such an important part of recovering from grief and bereavement. And this has been very severely restricted also, so that activities like sports, like musical activities, whatever activities you enjoy to do in your spare time has been closed down. So all these sources and strategies for coping has been disrupted or removed by the COVID-19 situation. And the consequences, of course, not only for the bereaved, but for the whole population, has been loneliness and isolation, rumination and fear. And what we have seen is that the focus of fear different in different age groups. So we have also seen that the oldest part of the population, which is the most risk group and which is the most affected when getting ill, are the least worried. The most worried seems to be, like also in the Vietnam case, the young people, the adolescent and the children. And what they worry about is very much focusing on, for the smaller children, worrying about losing their parents or losing their grandparents. And for the young people, very, very much being afraid of infecting their grandparents or other old people. So we have had a survey very recently where we have seen that a very large percentage of young people in Norway is very afraid of bringing the contamination on to older people. So they go in constant fear for this, and it's very stressful for them. There's a lot of distraction and pleasure. And what we have seen now at this point of the epidemic is that the whole population goes through an emotional exhaustion. We are so exhausted of being afraid and taking care and not exposing ourselves and anybody to the virus that we are all exhausted. And then, of course, we have seen aggression, suspicion, blaming and stigmatization to groups that we think has brought the virus to us. And then we have also seen moral injury and also very strong grief among health professionals, not necessarily because we have had such a huge wave of hospitalizations, because we have stayed clear of that actually. But there is a fear in the health professionals, there is a grief in the health professional when they have to close out relatives and not being able to support relatives of dying and sick person because they are going to prevent the virus. So taking care of the health professional is also a very important aspect of this. What we have done is to try to national-wide, by the authorities, by every kind of organization and NGOs, to have a wide distribution of information and self-help material in all digital platforms, and tried also to have focus on bereaved and grief in this situation. There has been an increased resources from the government to helplines and digital services, and the helpline report of an enormous increase in calls. And they also have reported an enormous increase in people calling in, talking about suicidal thoughts. We do not know actually that if the COVID-19 has caused an increase in suicidal rates, because we do not have reliable data on that as yet. But we at least know that there has been an enormous increase in suicidal thoughts, and especially among the young people, and especially among people who are grieving and bereaved. We have tried to have a strong focus on keeping psychological health services open, and especially in relation to vulnerable groups. Well, we have seen that vulnerable groups have been neglected, even if our health system is quite well equipped.
You are muted.
Yes, you have to unmute.
Okay, excuse me. We have also said, try to have resources to visitation service to the old and disabled. We have tried to encourage the use of streaming of funerals and other rituals where very few people can attend. And we have also encouraged use of pictures and diaries from the last part of hospital stays for people who are dying and dead. But we do know that these can never compensate for being present and to be close. And then, of course, there's been a variety of webinars available to all group of professionals. What should be done? What we have seen is in relation to grieving and bereavement, we have tried to encourage the health authorities to develop guidelines, standard guidelines for visiting routines in hospital and caring when patients are dying. And especially we want to underline the need to be flexible, that it is meaningless to just attend to allow one person to be on the side of a dying father or dying mother, that you should be flexible in the also in this situation to allow as many as possible can be responsible to be able to take part of the last part of the lives of their loved ones. What we see is that people can handle not being able to attend a funeral. They can handle being able to watch it online or a video recording. But what they can't handle is not to be allowed to be on the side of the loved one in the last part of life, because that never comes back and nothing can compensate for that. So we also have encouraged to the development of guidelines and resources for how to include bereaved in funerals and other rituals when the loved ones are dying or dead. And we also want to stress that there has to be more focus on young people's fear of harming older people, and also more focus on young people's grief and fear of losing their loved ones. And then we need to have a more systematic follow up of helpers, both to prepare, prevent, and reduce stress reactions, and also be focused on that also the helpers, the health professionals are grieving when somebody they are taking care of dies. So by this, I want to thank you for this opportunity to talk to you, and I look forward to the rest of the conference. Thank you.
Thank you so much, Ami. Such a profoundly important and yet such a difficult topic to address with this sort of, I believe that many on the call today will from their context know of the tension between the measures taken to prevent spread and sometimes the hard decisions and sometimes strictly enforced processes, and what you speak of the need for flexibility and compassion in shaping what those processes can allow for, because as you say, these are kinds of losses and moments of saying goodbye to loved ones that don't come again, cannot be had again. So thank you so much for that. We're running short on time. We're going to run a little bit late if people don't mind, because we really want to hear from everyone, but also have an opportunity to address some of the very important questions that are being raised in the chat. So I'd like to go straight over to our final presenter, who's going to be talking about ways of utilizing community-based remote MHPSS services in the COVID-19 context. Because as you know, I mean, in responding to provision of MHPSS, especially in large-scale crises, requires community engagement to mobilize supports from families, from community systems and social structures. But the very prevention measures that call for social and physical distancing really hinder some of the standard approaches that service providers are usually accustomed to taking. So it really challenges us to adapt our methods. So I'd like to invite Matthew Skojan, who's a research assistant associate from the Department of Mental Health at Johns Hopkins University's Bloomberg School of Public Health, to speak to us about these kinds of adaptations and what we can do based on his experience. Matthew.
Great. Thank you for that, Ananda, and to all the panelists before. And I know we've had a lot of information already in the nearly 2 hours we've been together. But as Ananda said, I'd like to talk today about the move from in-person mental health and psychosocial services to remote services during a crisis or event like COVID-19. And we'll be doing that through the process that our group, the Applied Mental Health Research Group at Hopkins, utilized with partners in Myanmar. So just a brief overview of the context that we were working with. We've been working in Myanmar with people from Myanmar since 2010 to develop together a valid assessment, a mental health assessment, as well as a mental health intervention that could be provided by laypersons at a community level here in Myanmar to overcome the barrier to accessing mental health services here in Myanmar, especially in remote areas and other conflict-affected areas like IDP camps. And since 2016 or so, we've been working in northern Myanmar and Kachin and northern Shan states with local partner organizations that are providing services in IDP camps there. So prior to COVID, we've already been working with these partner organizations that were providing a CBT-based intervention in person in the IDP camps, and we're up until this point able to offer services that were not available. For some context, in each of these states, there is one psychiatrist available for the entire state, and obviously not able to address all of the mental health needs of the population. So these community-based providers were able to really cover that gap. When COVID presented, this created an additional layer of challenge for accessing mental health services because movement restrictions placed throughout the world, and particularly here in Myanmar, there were strong restrictions placed on ability to move and particularly to access these IDP camps, which were seen as being extremely vulnerable because of limited health services. So initially, our team, working with local partners, looked at the initial clinical effects of saying, well, we could move this intervention to be done in a telemedicine type of modality using remote services and offering mental health services by phone. And we initially worked with our clinical team to start training the providers in how to provide counseling services remotely by phone. But one of the problems that came up was, well, first, will the client be able to access these services? Do they have phones to be able to call counselors? And also, how will others in the community that may need these services find out about them and even know that these services are available and also that they may need services like this? So some of the key needs that were identified was, how do we disseminate this information at the community level? How do we tell people about the stressors that they may be dealing with and possible coping strategies, including the availability of services such as mental health services, as well as who could help us provide those services. So in discussion with our global network and partners, as well as working alongside our local partners here in Myanmar, we developed a focal point system to identify local community members that would be able to support this effort in being a mediator between the mental health service providers that could no longer access those communities and the communities that are in need of this information and these services. We developed this operational guidance that we can put a link to in the chats as we move forward, and are offering that to all organizations as a guidance note in terms of how to move these services from and create this mechanism. So in addition to identifying these partners, we also help develop kits that could be provided to them to be able to implement these services, and adapted existing information around managing stress with coping mechanisms within there, and also helping to change unhelpful thoughts. In addition to having written handouts, we also saw the need to produce audio and video materials to help support this process, particularly for low literacy environments. We partnered with an organization, the Refugee Response, to produce 4 videos based on the handouts that were developed by our MHPSS team, and they've since been translated into over 22 languages and are all available on the YouTube channels, in addition to having downloadable files as well. One of the challenges in looking at this was that in low resource environments, we don't always have the ability to, or bandwidth to be able to utilize things like YouTube and other video sharing platforms. So we also worked on creating low Wi-Fi audio files that could be used either through loudspeakers or radio, and found alternate ways for our partners to be able to disseminate this key information on understanding more about the stress that they may be encountering and how to manage that stress. Now, within this focal point system, we also had to deal with the challenge of how to train people remotely as well. So this is another area that we had to look at innovative solutions for finding ways to be able to overcome the inability to have in-person training. And to that end, we created a training system that included written materials as well as videos in local language, and that were provided both online and in a downloadable flash drive that could be sent out to communities, and they could use as a resource if they didn't have the ability to do so online. We then followed up with discussions by phone or other platforms, and that included role play as well throughout different systems to help these community members that had no prior experience around mental health, to bring them to a place where they could disseminate this information and be this conduit, and also understand the scope of what was needed to ensure that they could help link the remote mental health services with the community as needed. So one of the key things I just want to mention is the ongoing need for support to ensure that there is a system set up and that people are feeling supported in the communities as we work through some of these challenges. So we did want to ensure that there were M&E systems set up and support systems in place to encourage supervision and connection to identify high-risk cases of suicide or homicide ideation and other high-risk needs, and ensure that mental health services were provided in those situations. So being cognizant of time, I just want to end with some of the areas that we've currently covered in terms of our partners reaching over 50 IDP camps with 70 focal points set up to date, and over 68,000 people reached through this focal point system. We're currently in discussions with other organizations around the country, and also interest in exploring regional expansion, utilizing this idea of having the ability to provide remote services in areas that previously weren't able to receive mental health counseling or services because of conflict or crisis or other challenges. Now looking at how we can utilize this and this learning that we have from COVID to expand this opportunity. Finally, I just want to really highlight that there are several other global resources produced by IASC, IFRC, and others, particularly the COVID-19 toolkit that was compiled by MHPSS.net. These have all been very valuable resources in working on providing guidance to transition and provide support during COVID-19 for MHPSS. Thank you.
Thank you so much, Matthew. And thank you for discussing both the challenges, but also giving us lots of specific tools and ideas about how we make those adaptations. We are sharing some links in the chat, but we will also be putting together some of these and sharing them by social media. And we'll share some of our handles at the end of the webinar, which is very close. But we've had a lot of questions, and some of the questions are specifically about particular bits of the work that you're doing or for more information. But given the limits of time, I'd like to put some of the more general themes that have been coming up throughout the questions to a few of you. And I'm grateful for Matthew, for you speaking about the challenges and systems for supporting volunteers. And if we can, we'll come back to that. But I've got a couple of key areas that people have asked about. And one of them is about the question of what you do in a context of limited resources. So there was a question about the IAC pyramid. The IAC pyramid is the idea that there are 4 different layers of types of interventions that contribute to improving a population's mental health and psychosocial well-being. At the base, there's the meeting of basic needs for and safety and security, and the provision of services in a way that is sensitive to those to enhancing resilience and well-being. Above that, there's a layer of supports that people have from families, from community structures, and so on. And above that are the more programmatic interventions that are provided perhaps by non-specialists to meet the needs of particular groups or particular individuals. And then right at the top, the 4th tier of the pyramid is often where you have specialized services provided by professionals for some of the needs that were mentioned. Now, in some of the contexts that you've spoken about today, we hear about needs at all these levels. But unfortunately, in the context in which many of us work, we don't have equal resources or interest at all these levels. And I'd just like to ask all of you on the panel, maybe if you'd like to comment on how you balance out and meet the existing needs in the population, given the limitations that you often have for available professionals at the 4th level, or perhaps sometimes at the bottom level, the fact that other sectors don't really know much about addressing MHPSS in food distribution or in dealing with medical services or perhaps administration of prisons, as Mark might be able to speak to. So I'd like to interview some of, invite some of you to comment on that question of how you balance the needs with the resources you have available. Maybe if I can invite Mark, Ronald, and Matthew to comment on that briefly.
So Ananda.
Yes, go ahead, Ronald.
Sure, I'm happy to take that question. Of course, this is the essence of the multi-level intervention pyramid. So like what I shared, generally in the Philippines, government is doing a lot of broad-based support systems because of our coordination role. But I showed with you in terms of our mapping study that, in fact, NGOs are giving more of the direct services. So most of these are the services found at the upper level of the pyramid. So we need to balance these interventions and have a way to work it out, within that system of collaboration. So government has limitations, but we have to do a wider reach. So online mechanisms are important, but I shared with you already some limitations of that. So the study is saying that we need to focus more on offline. Filipinos are basically people who need a physical presence. I mean, more than and agriculture. So we need to look more into that and explore more of that. But of course, not to. We have to observe as well the minimum health standards. So we need to use science to really, tweak the protocols that we have to make it happen, because there are limitations to what we're doing now. And I'm also particular about the digital divide. So as much as we do this online approaches, it's creating a lot of inequalities. So we have to pay particular attention to that as well. But of course, government cannot do it. That's why we need the presence of all partners. And like what I said, it all comes back to the need to improve capacities for MHPSS that we need to provide at the different levels. But most of the things that we really need to address the serious issues are really broad-based. So we have to make sure that self-care is there, psychological first aid. So the same old measures that we used to do in other crises should prove important. But I cannot really address effectively the challenges of work arrangements. Now your house is your school, the school for your kids. Now your house is your office. So I am myself challenged doing all of that. So I think we need to find some guidance using science to really be creative and innovative with the interventions that we're doing. So we need to think of those very creatively. So we have a lot of challenges, and we hope to get some inputs from other countries as well. So thank you for that, Ananda.
Thanks, Ron. And I think I like the fact that you pointed out that, these different sectors are now converging, with all these spaces are actually overlapping with one another. But I think your point is well taken about the need for complementarity in our efforts, and the need for kind of ways of working together. Now, Mark, I bet you that there are not that many mental health professionals involved with prison systems. What kind of advocacy might you be able to do, or might be needed, for example, to address some of the determinants of well-being of prisoners in a context like COVID-19? You're muted at the moment, Mark.
You're muted, Mark.
You're still Mark. You're muted.
Muted.
So one of the common challenges are the departments of corrections, who are very defensive if it comes to outsiders who come to tell them what to do. So a way around that is to build ownership for the problems they face. And so one way is in a very participatory manner to offer assistance in working with them on particular problems. So, but they dictate what they want to address rather than the outsider. And so it's a slow process, but you look at, the needs of the system. So you have staff involved, you have your inmates, and then you have your policy systems, and it's all geared towards security. What we see, for instance, in prisons nowadays is that up to 80% of the inmates are people who end up in prisons because of drug abuse. They don't belong in prisons, but so that's something COVID-19 has highlighted, that because the overpopulated prisons, especially in Asia. So nowadays, people within the justice system are a bit more sensitive to understanding that one way of dealing with these issues would be to not to incarcerate people who don't need to be incarcerated, so who need treatment rather than incarceration. But there was a dialogue which was impossible up to recently, but I think the COVID created some opening on there. So that's a good point. The other aspect is working together is very important. The example we have from Thailand, and my own experience with that, is that in the beginning it is difficult, yes, but finally at the end of the day it was the National Health Security Office that was playing a moderating role and bringing the Ministry of Public Health together with the Ministry of Justice and the Department of Corrections. And so there is a dialogue to ensure that inmates have access to the same quality of services as the general population, including mental health services. So, and there are a number of psychiatrists who are available and working with the correctional system. There is another aspect which I mentioned in my brief talk, is that often you see that prisons become a dumping ground for severe mental health disorders. So people who actually belong in a psychiatric institute end up in a prison setting. So, and that's not necessarily, and then again, the conditions in which inmates have to stay for a number of years is not conducive to mental health. So there is a lot of stress there. And so these are issues that need to be worked on. And there is opening, I think, especially if you go in a participatory matter, that they bring on the issues and you work with them to that. So there is ownership for these aspects. And as long you can convince that you're not there to undermine the system, you're there to actually strengthen the system.
Thank you for that, Mark. That's really, really helpful. But I think those lessons cut across multiple contexts where we're trying to work with well-established, often deeply entrenched ways of doing things. And we need to come with a degree of empathy for the perspective that other fields have and the good reasons why they believe they do the things they do. But as you say, it's a great opportunity in COVID to use some of the tensions and the pressures to broaden that perspective. Great.
Yes. Maybe one more thought in relation, not necessarily to prison settings, but more to a general population, based on the question, what do you do in resource poor situations? I think most societies have traditional systems in place, providing social networks for their community members in times of crisis, and that is often overlooked by professionals and by agencies. So I think that's an important aspect that can be utilized. The other aspect is there's a lot of advocacy necessary at the top of the pyramid, because there is this ownership. There is this is my territory, stay out of it. So you don't know anything, you're lay people. So, and then you have the middle section where you have the non-specialized professionals, health professionals, who do not want to deal with mental health issues because that's not in their curriculum. You can walk around all over Asia. Mental health is hardly present in medical practitioner curriculum. So it's very minimal. And so people are reluctant to face this kind of problems. And one way to open the dialogue is to connect, and I think COVID brings that, but also other conditions, to connect mental health needs with physical ailments, whether it is HIV or it is COVID or whatever it is, so that you can connect these things. Also in the sphere of the non-communicable diseases, whether it is cancer or diabetes and so on and so on.
Thank you, Mark. I'm afraid that we are really pushing the envelope in terms of the time we have. So there were other questions also about how one adapts to cultural, to country level, but also community level cultural specificities and needs. But I'm afraid that we will have to take that another time. But this is really an initial conversation that I'm afraid that we will want to take forward. We will also be wanting to find other ways, not just through webinars, but other ways of sharing content and so on. And I'd like to kind of in wrapping up, we'll be sharing some of the ways in which you can follow us and maintain the dialogue online. I think I would like to perhaps ask the panelists. I was going to open up the floor for everyone to have a last takeaway, but I would like to instead invite the panelists to type into the chat for panelists and attendees your takeaway message, because we've heard a lot in the last 2 hours, and I'm sure that there's stuff at the start that now you forget. But if you had one key takeaway that you wanted to have people think about when they return to work and life, what would it be? If you could put that in the chat, would be really grateful. We are extremely privileged to have all your inputs, and I would just like to kind of acknowledge the institutions that have come together to support today's webinar. But perhaps we will first hear, I think, Yvonne from Aslam.
Okay, thank you very much. It is really a very good opportunity for us to learn from each other, and I think this is not the end. It's only the beginning, okay, of a lot of webinars and communications like this. Okay, to inspire us with this closing note on mental health and psychosocial support, please welcome ADPC's Deputy Executive Director, Mr. Aslam Perwez. Take it away, Aslam.
Thank you very much, and to all the participants. And as I said in the very beginning, that the next 120 minutes is going to be very, very exciting. But I know that we added another 20 more minutes, but which is worth adding to it. And I really, I mean, personally, very much excited to hear all from the experts. I know that in this kind of format, question and answer at times becomes a bit limited when you have an online format. I wish that we very soon would have a similar gathering face-to-face somewhere. Nonetheless, I think I also take equal pride, particularly in this particular partnership. All of us coming together and making this happen was really very important for me. I mean, I have seen ADPC over the last 15 years, and public health in emergency or mental health in emergency in ADPC since 2003, even before I came. So, within ADPC, we have a commitment. We really would really want to explore more. For this particular subject, we heard, we learned, we certainly have to have greater investment. We certainly have to have more access, and particularly in areas where it is much needed. I mean, we all know currently the unprecedented situation that we are going through, and just imagine that a Rohingya camp in Bangladesh, where you have natural disasters, where you have ongoing this conflict based issues, and then of course a spat of COVID situation. This is where I suppose these things we really have to see how people access the knowledge, the expertise, and the psychosocial support. I'm really thankful for Ananda. I mean, particularly the MHPSS net for a lot of the knowledge resources that you have. But apart from that, the Center for Crisis Psychology of the University of Bergen, the Faculty of Public Health of Thammasat University, we are very closely working with them. And then, of course, Johns Hopkins University, Bloomberg School of Public Health, and then, of course, our support from the Norway. My personal takeaway is that this is a very important issue we must not forget. And I really admire what Professor Marx said, that you just cannot leave anyone behind, whether they are behind a bar or where they are like free bird like us. So with this, I congratulate my team here in ADPC, but at the same time, thanks all the experts. And we certainly would take advantage of this partnership and continue to do more in the near future. Thank you very much.
Thank you very much, and thank you very much to Dr. Ron, Uni, Eri, Matthew, Manik, Nuncharut, Dr. Min, and also to Kunwati. Again, we all say thank you to all our panelists and speakers, participants, mostly to our managers and directors of ADPC for supporting this. Thank you very much, and wishing you all a mentally and psychologically blessed holidays. Thank you.
Thank you, everyone. And if you,
thank you, everyone,
would like to just put your social media handles in the chat, then people will be able to follow you. We will also hope to share some of your presentations with your permission in the future with the participants. Thank you.
Thank you. Sawadee ka. Thank you.